Yes, hello and welcome everyone to Oral Pathology Tuesdays on Oral Pathology 360. And this time we have an oral pathology topic. I'm Dr. Mandana Donahue and I'm delighted you are here for today's session. We'll be diving into a fascinating topic in oral pathology, clear cells. Clear cell lesions, where we will be decoding the architecture. But before we start, let me share a few things with you. First and foremost, if you're watching from anywhere besides YouTube, that means if you're watching from our website or any of the many social media channels where you see the link and you see the video playing, well, you can watch it from there. But if you want to interact with us and be able to share questions with us, you need to be on YouTube. So head to YouTube and log into your account. For a clearer picture, especially today where we have histopathology images, you have to tap the settings gear and switch to 720p or higher quality of image. For those who are members, and you can get a certificate for attending. So you will need to be a channel member, which you can do by clicking the join button, which is right under the video even right now. And you can have to attend the live stream, then complete the certificate request form, which is shared. The link will be shared on the channel in the channel posts. And of course, you have to also say something, chat with us in the live chat so we know you're there, and then you will get your certificate. And yes, just before we begin, a quick reminder that registration is open for our upcoming masterclass on biopsy techniques in oral and maxillofacial diagnosis, which is happening on September 13th. But registration will close on September 12th, so well, don't wait any longer. You've got to register now. And yes, sir, reminder about our International Oral Diseases Case Presentation Conference. Do remember to save the date. Now, with that, let's go on. Let me bring in Dr. Tabita and welcome. So, it's a great pleasure to welcome you. And our speaker for today is Dr. Tabita Joy Chettiankandy, and I hope I said that right.
Yes,
Professor and head. I did? Oh, thank God. Okay, thank you. So, she is professor and head at Government Dental College and Hospital, Mumbai. She will be guiding us through some of her own cases and the diagnostic challenges of clear cell lesions. Well, welcome everyone, and wonderful to see everybody is already here. All our regulars are here. Wonderful. Hi, everybody. And thank you, Dr. Tabita, for joining us.
thank you, ma'am.
Welcome. Okay, as usual, we will hop on to the lecture. We will watch it and then we will come back for our discussion.
A very good evening to all viewers and audience. This presentation comes from Angshi, Mumbai, from the Government Dental College and Hospital, Mumbai. It's specially for the young and budding oral pathologists. The practice of oral pathology is more than what meets our eyes. With most clinical situations, there is often more going on than you can see on the surface, just like this iceberg. There are cellular, intercellular, molecular, and genetic aberrations which are happening within the tissues, leading to the clinical presentation. Hence, this quote from Tari Zameen Par is so apt and so cute, which says, जो दिखता है हमको लगता है और जो नहीं दिखता हमको लगता है नहीं है, लेकिन कभी कभी जो दिखता है वो नहीं होता और जो नहीं दिखता वो होता है. And this is exactly what happens in oral pathology practice. Every case is challenging and every case is a diagnostic dilemma. And to correlate it clinically and histologically is very important and often challenging. But the eye can see what the mind knows. Jean Martin said, to learn how to treat disease, one must learn how to recognize it. And diagnosis is the best trump in the scheme of treatment. So today, we will be trying to learn to unmask the lesions when the cells go clear. Myself, Dr. Tabita Joy, Professor and Head, Department of Oral Pathology and Microbiology, Government Dental College and Hospital, Mumbai, will be taking you through a few cases. Lesions on and off the gingiva are not uncommon in the oral cavity. They may masquerade as benign externally, but they are fulminating aggressive lesions internally, where the histopathological diagnosis is mandatory. So let's peep into a gingival lesion and its histopathological insight. The first case is a colorlessly colorful and oxymoron, which was seen in a 40-year-old male patient who presented with a chief complaint of swelling in the lower left back region of the jaw since 3 to 4 months. He had no relevant past medical or dental history. However, he revealed that he was being involved with deleterious habit of tobacco and pan chewing 3 to 4 times a day for the past 2 to 3 years. Patient did not have any obvious extraoral presentation, but his left submandibular lymph nodes were palpable, they were fixed, and they were non-tender. Intraoral examination presented a solitary, sessile, firm, lobulated, reddish pink growth in 3635 region, extending buccolingually and obliterating the buccal vestibule. It was 1 into 1 centimeter in size buccally and 4 into 3 centimeter in size lingually. The surface was smooth with edematous areas. Grade 1 mobility was noted with 353637. The lesion was soft in consistency on palpation. So looking into the clinical presentation of the lesion, a clinical differential diagnosis of localized gingival overgrowth was made. Could be a reactive lesion like pyogenic granuloma, peripheral tonsil granuloma. Since patient had habit, could it be oral squamous cell carcinoma? Also, the region is reddish in colors. Would it be a vascular lesion, or is it any other mesenchymal tumors? The patient was advised for radiographic investigations. The occlusal view showed a well-defined shadow on the lingual aspect of the left posterior region, which is suggestive of a soft tissue growth in that area. The panoramic radiograph showed horizontal bone loss in association with the permanent mandibular left second molar. With this, the patient was advised an incisional biopsy. On incisional biopsy, the H&E stain sections under scanner view showed parakeratinized stratified squamous epithelium and dense cellularity with vacuolated cells in the connective tissue stroma. The surface epithelium showed mild dysplasia in few areas, which was restricted to lower one-third, with areas of hypertrophy and areas of atrophy. While the connective tissue stroma showed nests of small, numerous polygonal tumor cells which were arranged in a precise alveoli pattern within the intervening stroma. Now, these spindle-shaped cells or the epithelioid cells with hypochromatic nuclei were also arranged in cords, short cords, or in small columns and separating the lobules of the clear cells. Under high-power view, the spindle-like or epithelioid cells were also noted. They were large, pale, with round or oval nuclei of varying sizes. They were pleomorphic and poorly defined, forming imperfect bands and bundles. Acutely angulated polygonal cytoplasmic outline was noted for these cells. While the clear cells under the 40X were pleomorphic, they were hypochromatic cells and had a clear cytoplasm which was suggestive of clear cells. So we started brain searching for the origin of these clear cells. So what we knew was that yes, physiologic clear cells, they might be epithelial, they might be mesenchymal, they can come pathologically through any metastatic tumors. So the epithelial tumors could be odontogenic or non-odontogenic in origin. The odontogenic mainly from the odontogenic apparatus, basically the cell rests of Malleus, the cell rests of Serae. The non-odontogenic could be from glandular or non-glandular origin. Non-glandular from the melanocytes, the Merkel cells, the Langerhans cells, or the cutaneous sebaceous adnexia. The glandular would be from the salivary gland or the mucous acinar cells, and mesenchymal could be from the adipocytes or it could be the metastatic tumor. Now, why these intracytoplasmic inclusion bodies were cleared is because they could be lipid-rich cells, they could be glycogen-rich cells, they could be mucin-rich cells, or they could be tonofilament-rich cells. So we couldn't find anything on the H&E stain slide. So when we can't find anything, we look at immunohistochemistry to lead us. So panel of markers, like an army to find out at the border what is happening, a panel of markers was done where cytokeratin, pancytokeratin, P63, S100, AE1, AE3, Milan A and HMB45 was advised for the patient. These cells were found to be negative for CK, P63 and pancytokeratin, were focally positive for S100, but they were positive for HMB45 at Milan A. Based on this finding, we gave a diagnosis of a melanotic melanoma on the incisional biopsy. When the patient reported after 15 days to the institute post-incisional biopsy, the lesion had grown much. It had become multilobular, fulminating lesion was seen. So the patient was advised for MRI, CT scan and PET scan to rule out any metastatic tumor. The MRI showed ulcerative thickening of the left alveolus involving the left gingivo-buccal sulcus. There was no bone loss, only mandibular erosion was seen. CT scan showed enlarged necrotic level 1B and level 2B nodes. Left level 3 metastatic nodes were seen. The CT scan of the thorax showed no evidence of metastasis, and the PET scan did not reveal any metastatic lesion. Based on this, the patient was given a diagnosis of primary amelanotic melanoma. So, amelanotic melanoma is not an homogeneous but a heterogeneous tumor. Now, because melanin pigment was not observed upon the H&E staining, the lesion was discerned to be a amelanotic type. Oral mucosal melanoma originates from the malignant transformation and clonal expansion of neural crest-derived melanocytes in the basal cell layer of the oral epithelium or the lamina propria of the oral mucosa. Now, some melanomas are devoid of pigmentation. Why? The first reason, one of the reasons could be due to deficiency in tyrosine, an enzyme necessary for the melanin production. Secondly, it could be that the enzyme system is actually intact and produce the melanin, but the quantity is insufficient to be viewed under the histologic H&E stain slides. Additionally, the production of melanin granules in melanosomes is distinctly regulated from the stage 1 to stage 4. In stage 1 and stage 2, there is change in the shape of the organelle without any melanin pigments, while in stage 3 and stage 4, melanin gets deposited. Therefore, true amelanotic melanoma may contain stage 1 or stage 2 melanosomes and not stage 3 or stage 4 melanosomes. The IHC staining may indicate the damaged step of melanogenesis. The Milan A or the MART1, that is melanoma antigen recognized T cell, is a membrane protein localized in the endoplasmic reticulum, the trans-Golgi network and melanosome, especially in early melanosomes, that is in stage 1 and stage 2 melanosomes. The HMB45 specifically reacts with silated PMEL17GP100 in the fibrillar matrix in the stage 2 melanosomes. The production of internal matrix fibers depends on the maturation and trapping of these PMEL17GP100, and in the presence of Milan A MART1, PMEL17GP100 produces melanosomal matrix fibers in the melanocytes. Now, in case of amelanotic melanoma, a positive reaction of both melan A MAT1 and HMB45 indicates the presence of stage 1 and stage 2 melanosomes. However, positive reaction to only melan A or MAT1 would indicate presence of only stage 1 melanosome. And if the IC staining showed only a positive reaction to melan A or MAT1, indicating immature differentiation of melanosomes prior to stage 2. However, the IC staining was positive for the human melanoma black 45 antigen and the melan A. So, the diagnosis was a melanotic melanoma. There are some criteria for this amelanotic melanoma. A, B, C, D, the clinical criteria is similar to what we have for all melanomas. The lesion is asymmetrical, it has a broad irregularity, it has color variations. The diameter could be more than 6 mm in diameter. To this, there could be other clinical findings which could be specific for amelanotic melanoma. That is, the lesion could be elevated, it could be firm, it could be in a rapid growth pattern. And to this, the 3 R's, that is, the lesion is red in color, it is a raised lesion, and it might show recent changes. So with this, the patient diagnosed with primary amelanotic melanoma of the mandibular gingiva underwent a radical surgery and was kept under follow-up for every 6 months. Patient was also rehabilitated for an oral prosthesis. However, the patient succumbed to a recurrence 1 year back. So this was the first case of amelanotic melanoma, where you can see the clear cells and how we can decode it in a case of amelanotic melanoma. The second case is of a 56-year-old female patient who complained of painless swelling in the left lower jaw region since 5 months. The family and medical history were irrelevant. On inspection, a diffuse swelling of size 4 into 3 cm was noted extraorally in the mandibular left posterior region. On palpation, the swelling was non-tender, non-fluctuant, it was intraosseous, it was firm in consistency. Palpation of the lymph nodes showed they were non-palpable, they were non-tender, the cervical lymph nodes were not involved. The intraoral findings, there was no specific findings on intraoral examination. However, a slight obliteration of the buccal vestibule in the mandibular left molar region was noted. Grade mobility, 1 mobility without any tenderness was noted with second and third permanent molars on percussion. Further, the orthopantomogram revealed an extensive multilocular radiolucency extending from the mesial root of mandibular left first molar to the distal portion of the third molar. The borders were partially well defined and corticated. We can see there was thinning of the inferior border of the mandible. The continuity of the inferior border of the mandible was also lost. Apart from this, the roots of all the 3 left permanent mandibular molars, they showed irregular spiked resorption. And the clinical and radiographic findings were suggestive of an intraosseous aggressive benign lesion. Could be ameloblastoma, could be OKC, could be any malignant odontogenic tumors, or it could also be a metastatic tumor, seeing the aggressive destruction of the bone. On aspiration, no fluid could be located from the lesion, and incisional biopsy was obtained under the GA. The H&E stain slides microscopically on this showed that the cells demonstrated a biphasic population of epithelial cells. They were proliferating in large lobular pattern. They were seen in sheets. They were also seen in small islands or in trabeculae or in strands. Under higher magnification, one population group comprised of clear cells having a polygonal outline. with well demarcated cell membrane and hypochromatic nuclei that varied in size and shape. You could also see basiloid non-vacuolated cell population having small dark hypochromatic nuclei with eosinophilic cytoplasm. Some areas showed well demarcated only clear cells with a faintly eosinophilic clear cytoplasm. Few of these islands at the periphery showed presence of low to tall columnar cells with reversal of polarity in some of the trabeculae or the strands. Palisading of the nuclei was noted in the polygonal cells, and the pattern was slightly reminiscent with that of ameloblastoma, where we could see that the epithelial cells were arranged in the form of sheets, strands, and discrete islands with nuclear palisading of the peripheral cells. There were clear cells, which can be seen with the green arrowheads. There were basiloid cells with eosinophilic cytoplasm, which are seen with the yellowhead, and tall columnar ameloblast-like cells, which are seen with the black arrowheads. So, histopathologically, it was found that it is a clear cell lesion. So, which clear cell lesion could it be? Because 90% of the clear cell lesions of the oral cavity either originate from the salivary gland tissue or from the odontogenic apparatus, and a few could be metastatic. So first we did histochemical stains. Periodic acid skip stain was done, which was, yes, it was positive, but it became negative on diastase. So it was pass diastase negative. We did mucicarmine to rule out whether it is a mucinous material, but it was negative. We did Congo-Red to rule out whether it is an amyloid-like material, but again it was negative. So we went ahead and we did immunohistochemistry. On immunohistochemistry, pan-cytokeratin was strongly positive. CK19 was focally positive. Calponine was negative. PAX8 was negative, and HMB45 was also negative. So, the clear cell lesions of the oral cavity, the diagnostic dilemma, the salivary gland origin was found to be negative because calponine was negative, although pan-cytokeratin was positive for epithelial tumor. Yes, CK19 was focally positive, suggestive of odontogenic origin. PAX8 was negative, which ruled out metastatic clear cell renal cell carcinoma, and HMB45 was negative, which ruled out melanoma. So the final diagnosis was given as clear cell odontogenic carcinoma. So the odontogenic carcinoma is characterized by sheets and islands of vacuolated and clear cells according to the WHO 2017 classification. The earlier synonyms were given as clear cell odontogenic tumor and clear cell ameloblastoma. But various authors have who had previously given these terms because of its similarity to the histopathological features. But now both these terms are obsolete, and the use of the term clear cell odontogenic carcinoma has been recommended by the WHO in 2017. In 2024 WHO classification of odontogenic bone tumors, clear cell odontogenic carcinoma is classified as low-grade malignant tumor from the odontogenic apparatus. Till date, more than 100 well-documented cases have been documented. Female predominance with a ratio of 1:1:6. Age is usually 40 to 70 years with a mean of 53 years. Mandible to maxilla ratio is 3:1. Three patterns can be seen histologically. It could be monophasic, which is very rare, completely clear cells. It could be biphasic, where at the periphery there is almost always a basiloid cell population of small, dark, unvacuolated cells, and this is the most commonly observed pattern. Then there could be ameloblastoma like Pattern may be focally reminiscent of the amloblastoma with an outer layer of columnar clear cells showing reversed nuclear polarity. So these glycogen-rich cells, which we can see in odontogenic tumors, may be because of the glycogen-rich, which is giving it the clear cell. Others may be because of lipid-rich, mucin-rich, immature zymogen granules. So the clear cells which originate may be either physiologic clear cells, they could be metastatic clear cells, it could be artifactual, they could be tumor clear cells, they could be cell senescence because of aging, or they could be the potentiality of any cell. Now, what is potentiality? Young budding pathologists, remember this. Potentiality of a cell is a sum total of all its latent capabilities, including every capability that will ever be expressed by the progeny of that cell. But that cell itself may not yet have had occasion to manifest itself. So here the clear cells were PAS positive, they were diastase negative, they were mucin negative, they were amyloid negative, and although glycogen may be lost during degasification or during fixation, the most reliable diagnostic markers were CK14, CK19, pancytokeratin. Chi67 proliferative index is highly variable. It is negative for vimentin, S100, desmin, SMA, that is smooth muscle actin, HMB45, CD10, CD31, CD45, and GFAP. Recently, we know that the rearrangement of the EWSR1 gene has been implicated in the pathogenesis of clear cell odontogenic carcinoma with activating transcription factor 1 as its translocation. So this fusion gene is a key molecular marker for CCOC, where we can see that EWSR1 with CRBR1 can also be seen in low grade of the CCOC. BRAF 5600E mutation can also be seen in some of these cases. So it's very important to know clear cell odontogenic carcinoma because it is aggressive, it has high recurrence rate, and it has the potential to metastasize. Treatment is usually complete surgical resection, adjuvant radiotherapy for cases showing soft tissue extension, aggressive growth or incomplete surgical margins. Metastasis is seen in 12% of cases, death is in 15% of cases, and median survival is in 14 years. In this case, the patient also did not survive because the patient did not take the treatment, and in spite of all counseling to the patient went back to the village and did not come back. So with this, we move on to our case 3. The case 3 is a lesion which was seen in a 46-year-old male patient who came with a chief complaint of 6 months of history. Patient had smoking and tobacco chewing habit for last 15 years. The submandibular lymph nodes were palpable, they were fixed. Intraorally, we could see there was an ulceroproliferative lesion with respect to 3738 and in the retromolar area. There was limited mouth opening. The root stumps could be seen for the upper teeth on the other side. Radiographic investigations showed no irregular bone loss. Now, histologically, on histological examination, this lesion turned out to be oral squamous cell carcinoma with clear cells. Now, we know that there are different variants of oral squamous cell carcinoma, and along the different variants of clear cell carcinoma, this could be one of the variants where IHC markers for squamous differentiation is required, where you can go for CK5-6 or are positive, cytokeratin markers are positive, mucin to rule out other clear cell tumors, mucicarmine, Alician blue histochemical stains can be done. Melanoma, to rule out melanoma, S100, HMB45 are usually negative. Now these clear cells in squamous cell carcinoma are glycogen, could be because of glycogen, could be because of liquid accumulation. They usually PAS positive and PAS diastase negative. With this, we move on to the 4th case. Just taking just one cases to know where all you can see the clear cells. Now, this is an 18-year-old female patient who complained of swelling in the right posterior regions of the palate since 2 months. There was no extraoral abnormality which was detected. Intraoral examination revealed soft, slightly fluctuant, sessile, non-tender swelling extending from the mesial of 1/4 to the distal of 1/8. Multiple areas of surface ulceration and erythematous areas was noted. Radiograph showed no bone loss in respect to 1/4, 1/5, and 1/6. The lesional area was excised, an incisional biopsy was done, and it showed epidermoid cells, mucous cells, and a lot of clear cells. Cystic and microcystic spaces were seen lined by the epidermoid cells and the mucous cells, and the clear cells were also seen in high number. So this was given as a clear cell variant of mucoepidermoid carcinoma. Now, the most significant issue with the clear cells in MEC is that they can make it challenging to distinguish the tumor from other clear cell tumors of the head and neck or the salivary glands, such as the actinic cell carcinoma, clear cell oncocytoma, or the metastatic renal cell carcinoma. The investigative markers which are used in MEC could be used for mucin expression, where high-grade tumors may show MUC1, low-grade tumors may show MUC2 and MUC4, MUC5AC and MUC5B can also be positive. The lesions are positive for CK7 and CK14 and negative for CK20. The patients with intraoral MEC have a reduced survival expectation, specifically if they are males, they have regional metastasis, they have a high-grade malignancy on H&E staining, and strong expression of PCNA, P53, and EGFR, or weak expression of CERB2. So, clear cell lesions can also be seen in a number of salivary gland tumors, and we need to rule it out. Another lesion where you can find clear cells is in varicopapillary lesions. Now, this is a 52-year-old male patient who reported with a varicopapillary lesion on the marginal gingiva in the region of 4546, and here we can see that the patient had a very small exophytic papillary overgrowth which could be just punched out with a clinical differential diagnosis of maybe simple papilloma, varicose vulgaris, or varicose carcinoma to maybe even squamous cell carcinoma, because the patient did have habit. So the histopathology showed hyperplastic parakeratinized squamous epithelium. The papillary projections were seen with elongated retiridges of relative uniform depth, and parakeratin could be seen filling the clefts or the crypts between the epithelial projections. The hallmark of this lesion was the presence of numerous large macrophages with foamy cytoplasm, typically which were confined to the connective tissue papillae, extending high into the papillae close to the surface. Now, these were looking like clear cells, so we did CD68, and CD68 was positive, which is basically for the macrophages, so the xanthoma cells, and the final diagnosis was given as Verruciform xanthoma. These xanthoma cells, they are foamy cells, they are large cells, they stain positively with poradic acid skip stain, they are diastase resistant, they are not glycogen rich. On gas chromatography, they have preponderance for cholesterol esters, and ultrastructurally, they may show fat-laden macrophages with the lipid content. Now, how do these macrophages transform to foam cells? We have activated T lymphocytes due to the chronic inflammation, which recruit the macrophages with the chemokine CCR2 molecules. And when there is upregulation of the expression of the macrophage scavenger receptor. So these macrophages recognize, they trap, they internalize the low density lipoproteins from the epithelial cells and oxidize it, resulting in the foam cells. And these foam cells express MSR1 and oxidized low density lipoproteins. And the MSR1 helps in cell sustenance of the long lasting verruciform xanthoma and the OX LDL acts as a chemoattractant for macrophages and T cells. So, to sum up, these clear cells can be seen in a number of lesions and could have a varied causative factor for its presentation. And these clear cells may be either benign, they could be malignant, they could be odontogenic, they could be non odontogenic, and a number of IHC markers need to be done in order to give a nomenclature and to classify it under a particular category. For the classification systems are important. The classification systems represent the language of both pathology and clinical medicine and provide a critical communication medium in establishing, applying, and validating therapeutic protocols to the patients. So, being an oral pathologist, we're attempting to assign a biologically correct label, one that precisely predicts the disease course of the patient. Now, as we are oral pathologists, I feel sometimes we have OCD. No, it's not an obsessive compulsive disorder that we have. But as oral pathologists, yes, we not only see with our eyes, but we observe, we correlate, and we diagnose. So that's how we have an OCD. So learn to see, learn to hear, learn to feel, learn to smell, and know that by practice alone can you become experts. Because diagnosis is not the end, but it is the beginning of practice. One needs to master the skill of differential diagnosis. And a clinician should always suspect a diagnosis and never expect it. Because जो दिखता है वो होता नहीं है और जो होता है वो दिखता नहीं है. With this, I would like to acknowledge Dr. Vasundhara Bhatt ma'am, Dean, GDCH Mumbai, Dr. Mandana ma'am, Team 360-degree Oral Pathology Oral Tuesdays. Thank you, ma'am, for this platform. Staff and students of Department of Oral Pathology, Dr. Ishwaran and Dr. Abhilasha Yadav from Oral Medicine and Oral Radiology and Oral Maxillofacial Surgery departments, because it is always a collaborative effect of clinically and surgically and radiographically correlating the lesions. My thanks to my guide, Dr. J.V. Tudkari sir, for all his support, and my student, Dr. Sanpreet Sajdev, for helping me out with this presentation. Thank you. Thank you so much.
Yes, thank you. That was a very interesting, and I like that it was really very foundational kind of a discussion and presentation. Very interesting.
Thank you,
So
ma'am.
while we are waiting for everyone to put their questions in,
Yes.
let me just tell everyone we have got a whole clear cell lesions playlist on the channel. Today's lecture is the fourth one that is gone there. And if you look at the playlists, you can well, watch these four lectures there. So, yes. So far, we don't have any questions in the chat.
Can
Um,
I say something, ma'am?
Absolutely, yes,
Yeah.
please.
Something that I wanted to comment was on the clear cell changes which are there in squamous cell carcinoma. Although WHO has not come up with a specific variant of clear cell, a variant of squamous cell carcinoma, but definitely we need to work out and see whether it is biologically different from the other lesions and whether possibly it could be added as a variant of squamous cell carcinoma.
Yes, true. Um, I think very often, like I told you earlier, I'm now a little out of touch with actual oral pathology, but from what I remember, some cases is that very often, if a salivary gland was closed, we could never be sure whether it is actually a change from the salivary gland, where the two things have collided or not. But purely a change in a squamous cell carcinoma is interesting and needs to be really checked if there is nothing else that is close by. Yes. So these are all from your own cases.
Yes, ma'am. These are all which have been reported in our institution. So all these cases are from our institute itself.
Very interesting. It's really nice to have, uh, especially some of these rare cases. Have you reported any of them? I mean, published any of them?
Yes, ma'am. We have published a few of them.
Okay, Dr. Akshay Trimuka has put a comment. Great cases, ma'am. Sometimes when clearing is marked in case of SCC, advised to do P16.
Yes.
So that
Thanks,
is his
Dr.
comment.
Akshay. That's very good.
Yes, we also have hi Nandini, and that is presence of clear cells indicate better prognosis or poor prognosis. Your opinion, Dr. Tabita.
Thanks, Dr. Nandini. Well, the presence of clear cells depends on which lesion you're finding it. Like in case of amelanotic melanoma, we found that it was amelanotic melanoma is very aggressive lesion. If it is in the salivary glands, the clear cell might show a better prognosis. But in case of squamous cell carcinoma, it has been shown that that could be a poor prognosis, or depends on from where the cell is basically originating, and the cell of origin demarcates everything from where the cell is actually forming a clear cell to know whether it is going to be prognostically poor or it is going to be better prognosis.
In case of something like amelanotic melanoma, it will be very difficult to decide because basically it is so aggressive. So it may be difficult to decide whether this is adding or not.
Yes, ma'am.
Okay, Dr. Rahul has got some question. Good evening, ma'am. Do these lesions behave aggressively? It's the same
Yeah,
question.
yeah.
Yeah, I guess it makes a difference. You it can easily be both sides of the coin, right?
Yes, ma'am. It
I mean,
could
if
be.
the cell has become clear, it may show that it is actually not as aggressive. On the other hand, the cell has become clear and lost its whatever differentiation, and therefore it might be a sign that it is aggressive.
Aggressive, right?
So it's so difficult. It can be just either of the two.
Yes.
Okay, Dr. Tara Dwivedi says, great cases, ma'am. Thanks for sharing. Is it possible to give the diagnosis without IHCs?
Dr. Dara, I think like few cases of clear cells which are very pathognomic, like maybe take for example lipoma. Lipoma also shows presence of clear cell. It is because the lipid gets washed off during processing, and there we can give the diagnosis without doing an IHC. But where you have a combination of cells which are present and the clinical presentation is totally different, in those cases, definitely we need to do an IHC to rule out the cell of origin, because that is what is going to help us in the prognosis and also in the treatment plan we are going to give to the patient further.
True. Sometimes you really just, when there is too much of confusion, you have to. Although I must say, sometimes IHC is not the magic bullet we hope it is, and it just goes and points to everything under the sun. But well, it's better than nothing. Yes. And okay, Dr. Akshay is agreeing with you and says, yes, depends on forward or backward differentiation. I guess, yes. Dr. Nandini is saying nice cases. Oh, by the way, as a interesting side note, today we have with us Dr. Alexander, who is in Australia. We have Dr. Hiller, who is in South Africa. We have Dr. Hafid from Libya, I think. Where was it? Uh, Yemen, sorry. So we have people from all over, and of course, we have all of us from India. Interesting spread of our audience. So, does anyone else have any more questions? What do you want to wrap up with? what is your takeaway message to everyone if they're facing a clear lesion? What should be the sort of a framework that they follow for the diagnosis?
Yeah. So if you are seeing a clear cell lesion on histopathologically, first of all, we need to rule out the most common lesions depend on the site, because some lesions are site specific. So you know that if the lesion is in the palatal area, or that could be a salivary gland tumor, so we need to rule out that first, this according to the site. Second, if whether it is odont epithelial innovation or whether it is a mesenchymal tumor. So you may go for cytokeratin first and check out the origin, whether it is epithelial innovation, whether it is a mesenchymal innovation, or whether it is a metastatic tumor comes last, because we know that metastatic to the oral cavity also definitely is there. Further down, we need to rule out whether it is of odontogenic origin or non-odontogenic origin, because oral and maxillofacial area is only the area where we find the remnants of the odontogenic apparatus. And definitely, we need to rule out the odontogenic tumors from the non-odontogenic tumors. And yes, IHC has now become very common, and we can take the help of IHC to rule out which lesion it is. Genetic aberrations and looking for genetic markers like ESW1, it is little difficult, it is little on the costlier side. But again, on HNE also, looking at the cell, the size of the cell, the architectural pattern of the cells, whether they are arranged in lobular pattern, they are in trabecular pattern, whether they're in sheets, whether they are present in nests, whether they are present in cords, whether they're present in strands, and whether how the cells are surrounding the clear cell also plays a very important role in coming to a diagnosis.
Very true. Sometimes it is equally important to rule out what it is not
Yes,
and narrow
exclusion.
the field. Yes,
Yes,
exclusion is equally
criteria of
important, I
exclusion is.
must. Yes. Yeah, absolutely right. So, yes, okay, we have Dr. Alexander who says, very nice from Australia. Dr. Sandhya says, great presentation. Why is it not showing? Okay. Yes. Hi, Sandhya, long time. Okay, and then we have Professor Hiller who says, okay, you zoomed into melanoma so quickly with your first IHC panel and utilized three epithelial markers instead of just a broad spectrum IHC for epithelium, S100, and Vimentin. S100 positive and Vimentin positive works quickly.
Thank you, sir. Actually, for
So,
this case, for the first case, that was a melanotic melanoma. We went ahead and we did a panel of markers. S100 was also slightly focally positive here and there. We did not do Vimentin because we were looking at more of an epithelial tumor in the first go. So we did the cytokeratin markers, and because the lesion was slightly a reddish lesion, nodular lesion, so we went ahead and we did the markers for melanin pigmentation. So we did Milan A and HMB45, which turned out to be positive.
yes, it was a good catch. Nice. Thank you. And thank you, Professor Hiller, for the question. And I was wondering how come you had not asked the question so far. Okay. So, uh, Professor Hiller makes among the greatest amount of contribution to all the lectures, I must say, with all his questions and insights. Dr. Priyanka is saying, great presentation. And Dr. Dwivedi is saying, thank you for your response. In my previous setup, there was no option of IHC, and we had to really rely on our knowledge and instinct.
Yeah,
So that,
that's true. That's true, Dr. Dara. Because, ma'am,
yeah,
it is a human intelligence which will always stay with us no matter how much advanced technologies and artificial intelligence comes up. Yeah.
true, true. But in today's world, you have to be very careful because, well, besides the fact that, of course, patients' health, but also is the fact that it could lead to great amount of problems medico legally.
Yeah.
So if a lab, I think, doesn't have it, you have to catch someone who does it for you. There are people who do this.
Yeah, but it's very
Okay, Dr.
challenging.
Dwivedi is attending from Ethiopia. Oh dear, yes. I can imagine that that's one more country. Interesting. And yes, I guess things can be very, very challenging when the resources are not there. Yeah. And possibly unlike us here, where we have access to labs doing all sorts of things, it may not be easily available there. Yeah.
Very true.
Yes, yes. Okay, it seems like we are done with the questions and we are almost on time. We're close to our closing time. It was a very, very interesting presentation and I really loved it.
Yeah.
It was really nice.
Thank you
Yes,
so much.
welcome. I should say thank you. And yes, Dr. Yes, you're getting a lot of very nice. Dr. Vilayat Ali also says nice cases. And okay, now let me just bring your, yes, certificate and let me hide this so we can see you. Right. Thank you so much.
Thank you so
And
much.
we hope you will be back.
Sure. Thank you, ma'am.
Yes, welcome. So let me also say thank you to everybody for being with us, for staying with us till the end of the lecture. And as usual, and as you know, this lecture will continue to be available on the same link after this. It is forever going to be there on YouTube. So if you want to share it with anyone, go ahead. If you haven't hit the like button so far, please do so now. And what else do I need to tell you? For those, quite a few were our members. So if you want your certificate, please see that you have already finished typing here. So just remember that you have to fill the form. The link is there in the post section of the channel. And in case any of you have any problem with that, well, just connect with me directly and I will send you the form. And what else? Yes, that's it. If you're joining us for the master class, remember you need to do so in the next 2 days. Registrations will close on 12th at midnight IST. And well, any which way, see you at the next session.
Yes. Thank you.
Thank you, everyone. Thank
Bye.
you, Dr. Tabita. Very, very nice lecture. Thank you so much.
Thank you so much, ma'am. Bye bye, ma'am. Bye.
Bye, everyone.
Bye.